Buonasera.
Hello. Buenas tardes. This is the title of my presentation, and the following slide just depicts my conflict of interests. So before getting into the guidelines, I would like to make a couple of points. What is driving the guideline? First of all, we all agree that LDL is causal to cardiovascular disease. So this is one of the pillars of the guidelines. The second point we all agreed upon, it doesn't really matter how you decrease LDL for the benefit, but what matters is how much you decrease it. And this is extremely important also to understand our recommendations. The third point that supports the guidelines are the genetics. In the last few years, we have learned that caring for a long time, small levels of changes in cholesterol that are determined by a number of different polymorphisms. You can see here PCSK9, you can see IKMG, CoA reductase, Niemann-Pick-C1 like 1, and others as well, which mimic the action of some of the drugs like statins, like ezetimibe, or PCSK9 inhibitors, brings a benefit to the subject. So this is supporting the concept that independent of the way you reduce it, which mechanism you use, you get the benefit that is proportional to the LDL decrease. The other important point is the benefit that come to us. In other words, you have to wait a bit of time to get, in relative terms, reduction and maximum relative risk reduction. That is 22 to 23% per millimole of LDL. As you can see here, in fact, in the first year, you have a lower effect as compared to the following years. And this is very important to interpret short-term trials, because if you stop at 2 or 3 years, the weight of the first year will be larger than 5, 6, or 7 years follow-up. Making a long story short with the genetics is also this, because some people take this as the indication, you know, the more you reduce LDL, the better it is, which is true. You know, the red line are randomized clinical trials, 5 years. The gray line has prospective cohort studies, 12 years. And the blue line is Mendelian randomization, 52 years. So this slide tells you both the cumulative effect over time, which is for 1 millimole will be larger for longer time of observation, up to more than 50% from the daily randomization, while at the same time, you can look at the other way around. If you have a very small reduction, let's say 0.4 millimoles, 4.5 millimoles for more than 50 years, you will get a benefit that is substantially larger than the benefit that you get for 5 years with an intensive intervention. Can you hear me?
Yes, we can. Yes.
Hello?
Yes, yes, we are hearing you.
Now, these slides report similar proportional reduction of risk according to any type of conditions. You may be diabetic, you may be young or old, you may look in several different ways. This is not the issue. No matter where you are, you get essentially the same benefit. And finally, another final point is related to the fact that depending on the reduction of LDL, you get a larger benefit. This is the number of events avoided per 10,000 treated patients. When you have a low risk, you get 1 millimole reduction, 170 events spared, which means essentially a number needed to treat above 75. Under the same circumstances, if you reduce largely LDL cholesterol, 2 millimoles, and in a very high-risk population, the number of events prevented is 1,440, which means about 7 as the number needed to treat. You see the disparity that may be linked to the type of intervention, but also to the risk. And this is an interconnection that always occurs. How to classify the risk then? We propose the score charts, which is an imperfect approach, but is one of the several you can use. The big problem with these scores is related to the fact that you tend to overscore people for risk, which are at older ages, as you can see here, because in 10 years, the likelihood to have an event is much higher as compared to younger fellow. We also propose to use some other approaches, and we can discuss that later. HDL, yes, they still play a role, and they modulate risk. And this has been shown in this table. So HDL may stay to be determined, but not as a goal for a target for therapy, but is a screening point and a risk determinant. So what we suggest for cardiovascular risk estimation is as follows. Total risk estimation should go with a score in people above 40 years of age. However, the ones who classify for very high risk or high risk without any scoring are those who have had cardiovascular disease, diabetes, chronic kidney disease, familial hypercholesterolemia, or those with elevated LDL cholesterol. High and very high risk are documented according to what I said, and these risk scores are not recommended as an obvious consequence of the first statement in people with FH or diabetes mellitus. The key messages are therefore that most frequently you need to address the concept of cardiovascular risk evaluation, because this is in the general population the results of interaction among a number of factors. The lipid profile should be considered in men and in women, for all of them above 40 or 50 for women. And a risk estimation, such a score, is helpful in primary prevention. but needs to be modulated. Why? Because there are a number of other factors that contribute that are not captured, such as, for instance, the presence of Lp(a), presence of calcium score, presence of a subclinical disease like carotid or femoral arteries plaques, and therefore it is only a guidance. And you have to go with your clinical experience. For instance, family history should be introduced in some of those scores. But what about the classification and risks? Now, the scoring goes for the people at very low risk. But very high risk are patients who have documented atherosclerotic cardiovascular disease, either clinical or on imaging. So people with stable angina, acute coronary syndromes, coronary revascularizations, stroke and TIA, or PVD are all classified as very high risk. Where we get more selective is with people with diabetes mellitus, because those with target organ damage or 3 or more major risk factors, or diabetes mellitus of type 1 long duration at a very high risk. Other people with severe CKD are at high risk, and obviously the people with a score above 10% or equal to. FH patient with atherosclerotic cardiovascular disease obviously classified as very high. High risk people are a class below in terms of risk, but still with a sizable amount of risk. And this is the score between 5 and 10%, or people with markedly elevated single risk factors. Of course, for cholesterol, we talk about 310 milligram per deciliter, or an LDL above 190, or for example, a blood pressure above 180 over 120. Patient with FH without other major risk factors classify as high risk. Patient with diabetes mellitus without target organ damage, or people with a duration above 10 years of diabetes mellitus, or another additional risk factors. People with moderate CKD that has been classified between 30 and 59. And then we go to the moderate and low risk calculation there, where you can see is between 1 and 5% for moderate risk, or patient with young patient with diabetes and a duration that is relatively short. Low risk is a calculated score below 1. What are the recommended lipid analysis? Well, you can see here, total cholesterol, HDL, LDL, and triglycerides. HDL, as I said, because it contributes to modulating risk evaluation. The others, because we'll see in a minute. However, non-HDL is also important and is recommended for risk assessment in people with diabetes or elevated triglyceride or obesity. A counterpart could be ApoB. So in other words, non-HDL and ApoB are believed to be reasonably equivalent. So whichever is available can be used to further stratify. And this is important because non-HDL cholesterol or ApoB are secondary goals in people with metabolic syndrome, with diabetes or hypertriglyceridemia. Lp(a) measurements. Okay, let's make it clear, this table, because there has been a lot of discussion. Lp(a) is an important risk factor, yet we do not know whether reducing it specifically brings a benefit. Having said that, when we say a level of above 100 milligram per deciliter, that is roughly 430 millimoles per liter, may have a lifetime risk of atherosclerotic cardiovascular disease equivalent to an FH. We only meant to say, to show how important can be isolated very high Lp(a). That doesn't mean that you have to care about only of those who are above 180. It just means that is a strong risk factor that at certain level is comparable to FH. So Lp(a) should be considered in selected patients, especially in those who show isolated increased Lp(a) in a family, so a familial history. Further, atherosclerotic femoral plaque burden on ultrasonography is one of the important things to be considered. And we also added the CAC score assessment because it should be considered as a risk modifier, especially in asymptomatic individuals at low or moderate risk. This table recapitulates all the recommendations and takes us to the point of suggesting whether to use only lifestyle advice or consider drugs, the yellow targets, or red, concomitant drug treatment. What drives this is essentially the benefit that comes from and the risk. So the higher the risk, the more intensive will be the approach and intervention with the red spots. And this time we have introduced also a subpopulation that is the one at secondary prevention at very high risk, where we suggest immediate drug intervention even if the people do have an LDL between 55 and 70, which is just suggested to consider in primary prevention. So what are the goals for LDL cholesterol? You can see from the previous slide that we suggested in secondary prevention, patients at very high risk, the goal is two types. One is the value, 55 milligrams per deciliter, 1.4 millimoles, below that, but also at least 50%. This is also true in primary prevention, but of course, the level of evidence is different. A for the first recommendation, C for the latter. And this is true also for people with FH. So please bear in mind, we actually have two goals. One is the number below which we should go, and the other is the 50%. In patients with atherosclerotic cardiovascular disease who experience a recurrent event within 2 years, not necessarily the same. So let's say a person had a stroke and then had a myocardial infarction or acute coronary syndrome within 2 years, those are deemed to be at very high, very, very high risk, extreme risk, you name it. And those we suggest a goal of 1 millimole, that is roughly below 40 milligrams per deciliter. Then we move to the patient at high risk, where we suggest an LDL reduction again of 50%, but the goal is less intensive and is below 70 milligrams per deciliter. So the take-home message is there are two goals there, and both of them should be achieved. In individual moderate risk, the goal is below 100. In individuals at low risk, the goal stays at 3 millimoles or 116 milligrams per deciliter. Now, this slide recapitulates what I said. Different goals, and for people at very high or high risk, a 50% reduction. How that is implemented in terms of drugs? Well, the recommendation is to start with a high intensity statin up to highest tolerated dose, which is different from the highest available dose. 1A evidence. If the goals is not achieved, consider ezetimibe, 1B evidence, and in primary prevention at very high risk but without FH, LDL goal is not achieved with the statin and ezetimibe, you may consider a PCSK9 inhibitor, where the level of evidence is relatively poor, as you may see, 2B, C. That means very little evidence for that. Then if we go to secondary prevention, then we do have a class 1A recommendation for PCSK9 inhibitors, as well as a class 1 level C for people at high risk FH. Then in patients who cannot tolerate statins, you can consider ezetimibe. And finally, you can consider also a PCSK9 inhibitor in those subjects on the top of ezetimibe. Now, let's go back and consider a couple of points. Let's look at the Mendelian randomization, what Mendelian randomization tells us. When you have together HMG-CoA reductase polymorphisms that reduce LDL cholesterol, so statin-like effect, as compared to Niemann-Pick C1-like one, ezetimibe effect, and you pull them together. In this paper we published a few years ago with Brian Fearens, you can see that the two things cooperate in reducing the rate of events. So that's exactly what has been seen and supports further the concept of having a combination therapy. And for randomized natural trials, the end of this study says that combined polymorphism, Niemann-Pick C1-like one and HMG co-reductase have independently linearly effective additive effects on LDL cholesterol and a log linearly additive effect on risk. So genetic evidence agrees very closely with randomized clinical trials like IMPROVE-IT. And this is a strong suggestion that the therapy with the statins and ezetimibe should be there and could also, in a way, help to reduce side effects, if present, of statins by decreasing the statin dose. And this is what we have seen with the IMPROVE-IT. IMPROVE-IT, although the reduction of LDL in terms absolute LDL reduction was relatively low, fitted exactly what you would have expected for such a trial in when it's reconducted for 5 years for the LDL reduction. So no surprise there, and that stays with the concept of LDL reduction that drives the benefit, independent of the drug you are using. But most important here is the level of LDL that has been achieved. You may have seen this data for PCSK9 inhibitor, but ezetimibe proved that essentially in combination with the statin long time before. You take here the population below 30, there were about 1,000 patients. You can see here, less than 30 milligrams per deciliter, an average of more than 6 years in the IMPROVE-IT. So, and the safety was perfectly fine. No difference among the different levels of LDL on trial, no matter myalgia, liver enzyme, neuropsychiatric disorders, strokes, non-cardiovascular, cancer. Everything showed that there was no effect due to the level of LDL that was achieved on trial. So below 30 was safe. 30 to 50 was safe. That does not to say there were no side effects, adverse effects, but they were not related at all to the level that was reached. Finally, 2 points on the guidelines, because the guidelines try to help to consider steps, but the concept of this figure is right here. That informs you that if you need a 50% reduction of LDL, you may achieve it with a high intensity statin. And that's one of the goals we have. However, sometimes you may be far from the goal, more than 50%. And to do that, you may need to put together high-intensity statin plus ezetimibe. It will get about 65%. Sorry about this figure, 60 should be here. A PCSK9 inhibitor, you will get 60%. And then when you put together all three of them, you can achieve up to 80-85% reduction of LDL from the starting point. How to translate then this algorithm that we have provided in the guidelines and that is linked to the level of evidence? You have to go through 3 passages. First, statin, not a goal, not 50%. Ezetimibe, not a goal, not 50%. PCSK9. But this is something that you can do practically. Well, the reason why we provided these estimates of the efficacy for statin or combination is just you to consider the point you start from. If you start from a very high LDL cholesterol, and this is my personal point of view, you shouldn't waste a lot of time. You have combination therapies that may allow you a 60 to 70% reduction of LDL cholesterol that will enable you to achieve a maximum possible reduction at the beginning to get to the goal. Then you can go into the tree with PCSK9 according, of course, to the reimbursement and to the severity and of risk in those patients. So to conclude, this is what we suggested. But to achieve the goals that we have proposed, you have now potent tools. And the starting point certainly are statins. But when you are far from the goal, more than 50%, you should frankly consider to put together the 2 drugs, ezetimibe and statins. All the evidence is there, genetic, randomized clinical trial biology that suggests this will be a very effective approach. Thank you very much for your attention.
Muchas gracias, profesor Catapano.